We patients never meet the doctors who judge whether our cells are malignant or not, and if they are, just how aggressively they're misbehaving. Routinely, we place our destinies in their hands. But what do we really know about them? To find out more, especially how pathologists and oncologists work together to get the most accurate diagnosis, I turned to two University of Michigan specialists, Dr. Kojo Elenatoba-Johnson, Professor of Pathology and Director of the Division of Translational Research in the Molecular Diagnostics Laboratory, and to Dr. Harry Erba, Associate Professor of Internal Medicine and Hematologist Oncologist.
The pathologist evaluates all of the information obtained, does a thorough assessment, and then amalgamates all the information in a cohesive fashion to communicate a diagnosis and prognosis potential in a report that's issued for access by the clinician, and it's recorded. So all of the information is recorded, and the clinician is capable of accessing, that being the oncologist, and all the patient's physicians can now access the information. Long is relative. Ideally, in well-oiled machines, as in academic medical centers and large comprehensive cancer centers, in uncomplicated cases, the turnaround time from the time the biopsy material is received in the pathology lab to the issuance of a diagnosis is typically within 3 to 5 days. In complicated cases that require ancillary testing, further ancillary testing, that time frame can be extended.
So, just as Kojo said, a long amount of time is relative. But as the clinician, what has happened is a person who was going about their business has been told that there's a mass that might be cancer, and time has now stood still for that person. So we can't possibly move as quickly as the person who has been diagnosed with a possible malignancy would want us to move. And it's just an impossibility. We would want the information immediately, along with prognostic information and the right therapy. The role of the clinician during this time is to continue to evaluate the person. So for example, making sure that if this is a malignancy, that the patient is stable during this process, that we aren't wasting time and putting the patient in jeopardy. Sometimes clinicians work with the pathologist saying, well, I need your best guess because my patient is this sick and I have to do something. What we want to do is make certain that we give the pathologist enough tissue and enough time to give us the best and most accurate diagnosis, because it's that diagnosis that is now going to lead to everything else that happens to that person in terms of what they hear about prognosis, the treatments they go through, and what they can expect from those treatments. So you want to get it right, and it will take the amount of time it will take. Every diagnosis of cancer depends on a skilled pathologist making that diagnosis. Most oncologists who are taking care of patients and about to prescribe chemotherapy or surgical procedures or radiation therapy, most of them want to be absolutely certain of the diagnosis as well. And so many times you will see the clinician going to the microscope and sitting with the pathologist to make sure they agree with the diagnosis. And so doctors who take care of patients with lymphomas and leukemias do this all the time, and in the solid tumors it happens as well, because this also helps to inform the clinician. It takes those, excuse me, Kojo, those dry words in the report and makes them that much more powerful by seeing it themselves.
You need to have infinite amount of trust in the diagnosis that's been rendered, and that is frequently linked to the skill level of the pathologist within that arena. And these days, the hope is that people can benefit from the equivalent of molecular smart bombs that target the specific molecular abnormality with the best consequence for the patient.